So sickle cell disease is a genetic disease. It's an autosomal recessive disorder, which means there's about a 1 in 4 chance that a child is going to be born with sickle cell disease. In the United States, there are probably over 100,000 people who have sickle cell disease, but it is a global problem. Every year, probably close to 300,000 babies are born with sickle cell disease worldwide, so it's a global problem. It's a chronic disease. It's caused by a change in one amino acid in the hemoglobin chain that results in the hemoglobin looking like it's sickled. That's how it got its name. And it's been around for almost 110 years when it was first discovered. Currently, the only cure for sickle cell disease is allogeneic bone marrow transplant, meaning that you transplant the recipient with somebody else's stem cells that doesn't have sickle cell disease. Sickle cell disease is now one of the more prominent diseases that ASH is interested, American Society of Hematology, as well as National Heart, Lung, and Blood Institute. Over the last 5 years, a lot of interest has evolved around sickle cell disease, and there are various aspects of research around sickle cell disease, from prenatal diagnosis to the use of hydroxyurea to reduce sickle cell crises or sickle cell complications, the use of vaccinations to prevent infections, the use of penicillin, pain management, looking into investigations of some of the late effects, including cardiovascular disease and liver disease and kidney disease and pulmonary disease. While gene editing or gene therapy is beginning to be investigated for sickle cell disease, the only known curative therapy for sickle cell disease is to do an allogeneic stem cell transplant from another human being that doesn't have sickle cell disease. Now, in the past, most of these transplants that have been done with a brother or sister in the family that's a perfect tissue match who also don't have sickle cell disease. It turns out that probably only 1 of 6 patients who might benefit from an allogeneic stem cell transplant has a brother or sister that's a tissue match that doesn't have sickle cell. So it leaves about 85% of patients without a potential donor. Over the last 10 years, we and others have investigated other sources of stem cells, including using adult unrelated donors or using unrelated cord bloods. However, both of those have had significant limitations in that, first of all, there are not many HLA-matched adult unrelated donors in the ethnic population that sickle cell disease arises in. And secondly, in the studies that have been done, there's been some serious complications of chronic graft versus host disease. In the unrelated cord blood transplant setting, the problems have been lack of engraftment. About 1/3 to 1/2 of patients fail to engraft when they get an unrelated cord blood transplant. So that leaves one other logical source, and that is to use a half-match donor within the family, which we call a haploidentical donor. And since almost all children still have a parent, there's a likelihood that there's going to be a haploidentical donor within the family, either the mother or the father. Now, our study took advantage that while we wanted to investigate this approach, we knew that in the past, limitations of using haploidentical donors have been either lack of engraftment, or worse, that it engrafts but causes very bad graft versus host disease, where the donor cells are reacting against the patient. So to circumvent that, we developed a multi-center, multidisciplinary trial that was funded under an R01 grant from the FDA, where we took haploidentical donors, and when we collected their stem cells, we selected out the cells that were rich in repopulating the bone marrow, but eliminated most but not all of the immune cells that caused the problem of lack of engraftment or graft versus host disease, what we call cellular engineering. So we cellular engineered the graft, by enriching for the rich bone marrow cells and added back a select number of immune cells. And for the patient then, we gave them a conditioning regimen before the transplant that was targeted so they wouldn't reject a half-matched donor. And then we had various supportive care measures that were in place after the transplant. And that was the design of what we had proposed to do. We transplanted 19 patients, and the median follow-up is over 3 years, the last patient being out about 1.5 years, the longest over 6 years. And there's a 90% 1-year event-free and overall survival. It was only about a 6% cumulative incidence of grade 2 to 4 acute GVHD and a 6% incidence of chronic GVHD. And now we've been able to follow up their cardiac, their lung, their neurological function, their quality of life, their immune reconstitution, their donor chimerism. So all the patients engrafted, all the patients have greater than 95% whole blood and red cell chimerism. They all have a normal hemoglobin. They have no more sickle cell disease or sickle cell symptoms. Their lung function is stable to improve. Their cardiac function stable to improve. Their TRJ velocity stable to improve. And they have significant improvement in their neurocognitive function and significant improvement in their health-related quality of life. We want to confirm the results. We're doing a second trial now, but if these results are confirmed, this opens up the possibility that every patient with sickle cell disease who has high-risk features, which was defined in our study, has the option of having an allogeneic transplant from a family-related member. Could be a brother or sister, could be a mother or father. This will open up the possibility that every patient with sickle cell disease who is in need of a transplant has a donor and can have a transplant.